Hey guys, it's Nurse Gwenny. Let's talk about rhabdomyolysis, or just rhabdo for short. Rhabdo is where we have massive muscle breakdown, and then our kidneys get clogged up with all those intracellular guts being released into the vasculature, and we get an acute kidney injury, or as we just call it, an AKI. Now, how do patients get this? Well, there's several ways. If we have an elderly patient who has fallen down their stairs and they're laying on the basement floor for a couple of days before anybody finds them, from laying on that hard floor, they're going to have lots of muscle breakdown and then that AKI. I've seen it in patients in status epilepticus, where all that exertional movement from that seizure for 30, 40 more minutes causes them to develop rhabdo. Patients with crush injuries, where say a trench falls on them and crushes their quad muscles, or exertional rhabdomyolysis, which I myself got one time from greatly underestimating how difficult this hike was and overestimating my own abilities. And I'm sure you've seen that in somebody who, say, went to go try CrossFit for the first time and they went a little bit too hard. So what are we going to see in these patients? Number one, they're going to have catastrophic, out of proportion pain in whatever the affected muscle group is. We're also going to see that hyperkalemia, which is because all of those cells, remember, hyper K is an intracellular ion. When we break open all those cells, that potassium is now running amok in the vasculature. And our concern there is going to be those fatal dysrhythmias that we see with hyperkalemia. So you can hook the patient up to a 12 lead and take a look. You're going to see the peaked T waves, the prolonged PR interval, the widened QRS complex. And to manage these patients pre-hospital, they require massive fluid resuscitation. I'm talking 3, 4, 5 or more liters of fluid. And to manage that hyperkalemia, we're going to give calcium, which essentially just tells the heart to chill out. We know there's lots of potassium. Don't go into one of those fatal dysrhythmias. And then we can give a continuous albuterol nebulizer to help shift some of that potassium back into the cells. Once we get them to the hospital and we get a full set of lab values, then we're going to pregame them with some dextrose and then give some insulin to further shift that potassium back into the cell. But don't forget, we've got to treat what's broken, and that's the kidneys. So sometimes we can fix this in maybe mild to moderate cases of rhabdo with that massive fluid resuscitation. But some of these patients, we've injured their kidneys so severely that we have to send them to dialysis, or in the worst of cases, to CRRT, continuous renal replacement therapy, in the ICU. So now you know what to look for in your rhabdo patients and how to take care of them pre-hospital.